So good afternoon, everyone. We are going to go ahead and get started. I would like to thank you for joining us this afternoon for our second session of the Behavioral Health Learning event. My name is Courtney Wheeler. I am one of the Public Health Program Managers here at the National Indian Health Board, and I'm going to be moderating your session today. We are grateful to have Pam Indicorn from IHS join us this afternoon. She will be presenting on the National Mental Health Crisis and Suicide Prevention number 988. I just want to make everyone aware this session is being recorded. We are asking that all participants remain muted and leave yourself on mute until the presenter asks you to. And that will probably be during the Q&A session where you guys can provide feedback and ask your questions by unmuting yourself, or you can raise your hands as well and I can unmute you. You can also type your questions or comments in the chat box as well. I will be moderating that and we'll share your questions or comments with Pam. I also want to remind everyone that at the end of the session, you will be required to sign out using the link that you received in your email. And I will also provide that link in the chat box. Using that sign out link, you will be able to receive your CE credits. Once you complete the link, you will be sent to the evaluation. We are asking that everyone complete the evaluation just to give us feedback on the sessions. It also helps us plan for future webinars that we would like to present around behavioral health. So again, thank you so much for joining us, and I will turn it over to Pam so she can begin.
Good afternoon or good morning, wherever you are. So today we're going to be talking about 988 and the rise and how it came to be and what we're looking at and eventually what we hope it becomes. But specifically, we want to focus on the impact on rural and urban tribal communities, trust lands, and federal reservations. This is me. I'm Pamela Indicorn. By training, I'm a clinical social worker. I've got my undergraduate and graduate degrees from the University of North Dakota. I'm getting a doctorate at the University of Pennsylvania. Currently working on my dissertation right now. And so I bring about 14 years of experience in suicide prevention, worked in VA, worked in IHS, worked at all different levels from local level through regional VISN level up to IHS and headquarters. I've been here in my position now, I believe about 6 years, really focusing on suicide prevention within tribal communities and doing more of a public health approach upstream when it comes to suicide prevention, meaning really empowering and advocating for tribal communities and tribal programs, because that's where the work is done. The work is not done here at headquarters, it's done out in the communities. So we really want to pay attention to that. But also, everything that we do is going to impact those communities. And so whatever we put into place, we need to make sure it's going to work for tribal communities. Disclaimer. So everything I'm going to say here today is from what I understand, through my education, from what I know. These do not reflect the policies or positions of the U.S. Department of Health and Human Services or that of IHS. So as I like to say, as many others like to say, what I'm going to say here, please hold me responsible for it. This is my discussion presentation. Don't blame IHS. Let me know if you have any thoughts and concerns or want to have questions. Feel free to ask questions. I really recommend questions. I highly would appreciate it. I really feel like this is a topic that a lot of discussion has to occur on. And so over the last few weeks, months, really pushing to get more information from tribal communities, from programs to understand what's going to happen, because I don't know what's going to happen. So your feedback and what you question me about, provide your thoughts, your observations, it's going to inform me as I go forward as well. So what do I hope that you're going to take away from today? Basically, what was the timeline of 988? What's going to be the impact, or what could be the impact? And then how can we look at that for future directions as we're thinking about implementation within Indian Country 498? What is it going to look like? We don't know. But hopefully we can start to build a process or a platform where we can start to really think of ways that we can create it and help tribal communities to get there, help reservation, tribal land, urban organizations to really be prepared to start to work with 988. So what is 988? 988 is the 3-digit number that was proposed by the FCC in July 2020. Like 911, 988 is what was proposed as a 3-digit number that would have all of the National Suicide Prevention Lifeline calls, the 1-800-273-8255 or 1-800-273-TALK calls, be routed to. So instead of dialing 1-800-273-8255 or 1-800-273-TALK, you can just dial 988. And what would happen is that that call would be answered by a local crisis center within the state or area from which the call is originating. An example, I'm from South Dakota, born and raised, Pine Ridge Reservation. If somebody at Pine Ridge calls that number, they would then be routed to the crisis center in Sioux Falls. And that crisis center would be then the ones who would respond, work to de-escalate the situation, do a follow-up, get referrals. That is what would happen with 988. It would then go to that crisis center, and then the crisis center would respond. In that time, since 988 has been implemented to now, June 2021, a number of things have occurred. First and foremost, SAMHSA, the Substance Abuse Mental Health Services Administration, has created national guidelines for behavioral health crisis centers. So all of those crisis centers across the United States, they've all have been given new guidelines of how do you deal with suicide crisis, how do you deal with mental health crisis. Now, I do want to give a really big shout out to the SAMHSA, Substance Abuse Mental Health Services Administration, the Suicide Prevention Branch. Richard McKeon is a Suicide Branch Chief. The nice part about working so close with SAMHSA is all the information I'm presenting to you today comes from SAMHSA, because SAMHSA is the point of contact for implementation of 988 nationwide. So SAMHSA has been wonderful in helping IHS, VA, all the federal agencies to start preparing for the rollout of 988, and has been instrumental in pulling together information. And in fact, SAMHSA has really recommended that we as a special population provide feedback to SAMHSA on how is 988 going to look in Indian country. And this is something that we're in the process of doing right now, is gathering that information from as many sources as possible in order to then provide that back to SAMHSA and say, hey, this is what the implications, these are the challenges, these are the barriers, these are the opportunities that we see for 988, and give that feedback to them. But in addition to that, we're also really working hard to notify tribes of this is coming. This is something that we all have to be prepared for, because once it rolls out, it has the capacity, the opportunity to really make a change in our communities. And how can we help that? How can we foster that? What do we need? That's always the question I always ask programs that when we talk about things regarding suicide prevention is, what do you need? What do we need to be ready for 988? And then, of course, expansion of the SAMHSA certified community behavioral health clinics. Now, expansion of services is one of those key components that I have brought to me a lot. If they have a caller from our tribal community reservation urban center and they reach a crisis services center, is that crisis service center able, and do they have the capacity to be able to engage that caller when they're in their crisis, and then eventually get them to the next step for services that may have cultural awareness, cultural humility, and cultural competency, possibly. That is something that we have to work towards, and that is something that is very relevant, because as you know, tribes span all of the United States and Alaska. We have to think about it from this perspective of every tribe, all 574 tribes. So these are some things that we have to pay attention to. But in addition to that, we also have to pay attention to the uniqueness of every tribe. Tribes that are up in the Pacific Northwest are very different from the tribes down in the Great Lakes area over to the Four Corners, very different. And so what do we have to push forward to be able to help people, help them get the help that's appropriate, relevant, and adequate to meet their needs? This is something where I would hope that you, and I would invite you to talk to me about and tell me, hey, this is what we really need to think about. Hey, this is what you need to consider. Hey, you need to add this. Or, hey, go talk to so-and-so. Feel free to do that, because I can't do this alone. And I always tell people, if you want to be part of the process, you want to be part of it, let me know and be part of it, because suicide prevention is very difficult work. And now with 988, it's going to be stepping out of that silo of just the National Suicide Prevention Lifeline, the Trevor Project, and the Crisis Text Line, as well as even the new Trans Lifeline. Those silos is now going to be opened up across the board with 988 in the inception of this 3-digit number. So let's have a discussion. Feel free to ask questions. Feel free to give me your thoughts. I really want to hear them. As we go forward, we have to think about this designation. It was actually established in statute, so this exists in law. That's very important to understand, because this isn't something that's just going to come and go. It is now in law. So like 911, 988 is now permanent. It's going to exist. That means you're going to see features eventually, hopefully, that telecommunication providers are going to allow 988 to be called like 911. So even if you don't have minutes or availability of a phone call, you can still dial 911. Hopefully we will get to the same place, and really the statute does indicate that we should be getting there too with 988. And 988 should then be able to get you to the services that you need. And we'll talk more about what those services are hopefully to look like, or what is planned to look like as we go forward. But again, these are plans, best laid plans, I always say. You never know if they're really going to work. But when 988 was established under the National Suicide Prevention Hotline Designation Act, so FCC did the original, we're going to do 988, and here's what we're going to use, and this is what it's going to mean. Then that went to Congress. And Congress in October 2020 wrote, passed, and then signed into law the National Suicide Prevention Hotline Act. And what that did is it authorized states and localities to institute fees to fund 988, similar to that of 911. And it also called for 2 reports. It called for a report from FCC, and it called for a report from SAMHSA and VA. And the reason why it called for a report from SAMHSA and VA is because SAMHSA actually funds the National Suicide Prevention Lifeline, 1-800-273-8255, as well as VA, who funds the Veterans Crisis Line. That is a caveat to the National Suicide Prevention Lifeline. Press 1 if you're a veteran. Those reports are what were used by Congress to inform themselves about what does this look like, what does this mean, what are some issues that we have to pay attention to. Perfect issues, texting and geolocation. So let's say somebody calls the Lifeline and they say, I'm suicidal, I'm thinking of taking my life. And the Lifeline is trying to de-escalate the situation. And let's say the person accidentally gets disconnected because they go out of range from the tower. That can happen. Or they hang up. These reports to Congress have to take those in consideration. Geolocation, meaning how do we find them in space in the United States? How are we going to find them? Are we going to be able to ping cell towers and find them, their geolocation? Where did they call from? And it asks them to talk about texting. Because right now, only very few pockets of 911 actually can receive a text. Very few. There's only, last I heard was like 3. Because that's next gen 911. And this is something that we may need when we're talking about 988, because we know that there are certain segments of our population that use texting more than phone calls, specifically the younger generation. So we have to have those availability, and those are reports that are due to Congress actually now, as we need to think about all these things. And the timeline for implementation, when does 988 go live? July 2021. So here we are literally a year out from when this is going to come into being. So we don't have much time, but we do have time. So we have to look at all the implications when it comes to 988. Another piece that really falls into this was the Surgeon General's call to action on suicide prevention, specifically for crisis care. Now, the Surgeon General, not since, I believe it was 2005, was the first call to action for suicide prevention. They've now updated that call to action to really focus on what are we seeing now in regards to suicide prevention. If you haven't seen this call to action, if you haven't had a chance to read it, feel free to send me email. I'll give you my email at the end so that you can look at it and you can read through it and see what is it that we need to pay attention to. But what the call to action did specifically to crisis care is these specific recommendations. The first one being increase the development and use of statewide regional crisis service hubs. Now, certain states have crisis hubs. One of the ones that I'm familiar with is the state of North Dakota, because I have my license in North Dakota and I worked in North Dakota before working for both VA and IHS. Those crisis services hubs provide crisis services to the local region. Now, I worked at the Southeast Human Services Center in Fargo, North Dakota, and they had a crisis line that they picked up 24/7 and people had to get care. They would call that line, they would get triaged, and then they would help them find a bed if they needed a higher level of care, like the inpatient psychiatric unit bed, or they would get them into the system for either individual, couple, family counseling, or they would work with them if they had legal issues or homelessness. So when we talk about those crisis service hubs, we're talking about hubs like that. Where do they exist? Currently, certain urban locales actually have more than one. Some have 2 or 3. And then some states have none. So we need to increase and develop those for statewide or regional in order to meet the needs identified. The other one, increase the use of multiple crisis response teams. Oh, this is a big one. We talk about this a lot, and this is something that when I'm talking with others, especially other federal agencies in SAMHSA, about this model, is the model right now as they're looking at it is basically an air traffic control model is what they like to liken it to. Meaning that if the person in crisis calls 988, what they want that crisis service center to do is to act as an ATC, get that person care at the moment, de-escalate the call, and then move them on to a higher level of services or a referral or get them into care. One of the pieces that they're proposing are mobile crisis teams. They want that crisis service center to be able to dispatch a mobile crisis team. And in certain urban centers, specifically Phoenix and Maricopa County, they have such a situation, such a type of program. So does Georgia and Atlanta. They have this availability. Now, within our tribal communities, I know of a few tribes that actually have this availability. I know Navajo Nation does a great job with this. They actually have 3. And I know that they also have a lot of limitations, though, when we're dealing with mobile crisis response teams. First and foremost, funding. Second of all, location. And so when we talk about the increased use of mobile crisis teams, especially for tribal areas, especially for rural areas, this is a piece that if you have feedback, let me know, because this is the piece I'd really like to have a discussion about. Because as we've been discussing this in all of the meetings amongst federal partners and with SAMHSA, that was my concern, was that how is this going to work up in northern Montana from if you had somebody at Fort Peck who needed care and needed to get to an inpatient hospital, how was that going to work in January? How is this going to work when we're dealing with situations where distance is a factor, time of year is a factor, access to services, because the only place you might be able to get an inpatient beds, Billings or Great Falls, how is that going to work? And how is it going to work if the mobile crisis response team has to travel hundreds of miles and hours down the road? So this is a piece. Feel free to jump in if you have any thoughts, and let's have a discussion about that, because that's one of my main concerns. The other recommendation, increased use of crisis receiving and stabilization facilities. This is a big one for us because we know, because of the wide geographic locations and because certain states don't provide services and funding, and we know IHS, we don't have the funding to provide these type of services. What are tribes going to do? How are we going to deal with this? This is one of those big, blatant, what do we do? You tell me, I'll gladly take it forward. Because right now, what I can say is that we're going to have to map out tribal communities, and we're going to have to partner with tribal communities to start mapping this out and understand what do tribal communities have access to and what don't they have access to. And what they don't have to have access to, what do we need to do about that? Who's going to step in? Who's going to talk about this? Who's going to advocate for this? How are we going to advocate for this? What do we need to do? Next recommendation, ensure safe care transitions for all patients at risk. Again, another big one. Because what happens now is that if a patient is at high risk for suicide, and the receiving doctor, most likely in an emergency room, makes the determination that that person needs to go to a higher level of care, such as an inpatient psychiatric unit, maybe under a mental health hold, then where they go, especially for our tribal communities, that unit or that hospital can be hundreds of miles away. They can have limited beds. They may have no beds. We're coming out of a pandemic. This was one of our biggest issues during the pandemic, is because a lot of EDs and a lot of psychiatric units were diverting because of COVID, because people were infected. And they did not want that to go on in either the patient becoming infected, because they would have to go through that receiving facilities ED and then go on to a unit where somebody else could be infected, or have them come on and infect others. So that became another issue. How do we ensure those safe care transitions? How do we ensure that those that are receiving the patient is safe? And if we're doing this in the winter, how's that going to look? Again, what does this mean to Indian country? And lastly, ensure adequate crisis infrastructure to support implementation of the National 988. I love this recommendation. I think it's one of the most important ones. Save the best for last, because we really need that infrastructure. I had the privilege and honor to speak to the Tribal Technical Advisory Committee under SAMHSA a few weeks back, and we had a conversation about this. And President Nez from Navajo Nation was so eloquent in his statement of, this is something we've been calling for years. He's like, infrastructure is such an issue for Indian country. What do we do about this? Because we have communities that don't have access to cell. We have communities that don't have water. How is this going to work for tribal nations, tribal communities? And this was something that was echoed by tribal leader after tribal leader after tribal leader. What about the infrastructure? If we don't have internet now, what do we do? And what does that mean as we go forward? Now, I know that Vice President Kamala Harris announced that tribes have the availability and ability to apply for a grant to help with cellular services, infrastructure, internet services. When that's coming out, I don't know, but I do know that that was announced about 3 weeks ago. Have yet to receive any hard data information about that. Once I do, I'm planning on basically postering it everywhere, because there are tribes in the United States that need access to services, and how do they build that? Right now, under the FCC, there is a mechanism that tribes can do matching. So if a tribe wants access to internet services, they could put matching up funds that the FCC will match that will allow them to get internet access. The issue, and I've run into this over the years a number of times, of getting that kind of access and infrastructure is a lot of money. I always liken it to Havasupai down in the canyon. You know, if you're talking about getting them internet access, they're in the canyon. That is going to be very expensive. And how can and expect them to put up the same amount of money which the FCC is going to match. And in fact, Havasupai tends to become the issue that I bring forward a lot, because Havasupai, they have the right to be on their tribal lands. That is where they are. They should not have to leave. They should not have to be inconvenienced to get services. And so the question I always have is, how is 988 going to help Havasupai? Because that ultimately is my responsibility, is that if we want Havasupai to have just as good a mental health and crisis services as my tribe up in South Dakota, what are we going to do about that? Where's the equity of this, and what can we do to help equalize that? So what are our key issues? Our key issues, of course, is we need to assure that there is capacity. Capacity is one of the biggest issues we're going to run into. We need to coordinate that care. How do we do it? When we're looking at FCC, it should be coming out now, their report on texting. They also should be coming out in the report on geolocation if that's something that they're going to push or support for 988. So waiting for those reports to be made available. And then when we're looking at 988 and 911, what we hope, and what I would hope, is that 988 take off some of the burden and ease the burden on 911. But here's the other issue. Not a lot of our tribal communities have good sustained 911 services. Some don't have any, some have some, but to a limited degree. How is this going to interact with those tribal 911s? How do we establish a network of crisis services to help tribal communities? Big one, because right now we struggle to do that. This is the reality of our tribal communities, and it's very difficult, but how do we need to think about this to create something new, to create something maybe that's already established and expand it? What's out there? We have to ask these questions and really to start thinking about it from a bigger perspective. And how can we develop this, and what could we create as a roadmap? Finally, SAMHSA is working with us and IHS that we're looking at what kind of report can we give back to them and say, hey, you need to be thinking about this and that, and giving them input. And so this is where you come in as individuals who are working in these services, as individuals who understand what's going on in tribal communities and tribal programs and urban centers. What's out there? What is it that we need to pay attention to? I had one urban center say to me, right now we do provide behavioral health services, but the local crisis center does not send those individuals who call and they're native and they're self-identifying. They don't send them to us. How do we make sure that that connection is made? And similarly, I have had a couple of states email me and say, hey, I need people to join my coalition. Can you help me find somebody? And my limitation, I'll be transparent, is I can ask the tribal leader, but tribal leaders are very busy. And if you're going to build a good, sustainable coalition, you need people who are working in this area that's on the ground. Not necessarily our tribal leader, although the tribal leader needs to be aware and needs to give not only their support, but understanding to this, but you really need those community members. And that kind of coalition building takes time. It's not something that just happens overnight, because a lot of times our communities, they don't know of those crisis centers in the state. We don't have a lot of relationships. Some tribes do. I know my tribe don't. Some tribes do. And so we have to have that. And how do we build those? And who's open to being part of that? Because we got lives, we got families, we got issues of our own. And being a part of a coalition, that needs to be really made of like, what's the expectation? What's your timeline? What are you needing? What are you not needing? So the coalitions themselves for the states really have to be more upfront and transparent about what they're asking versus just say, send me somebody, because you really need people who are in the know, who are dealing with this on a consistent basis versus just anyone, because just anyone may not have what's needed within the community to really meet the needs of the tribe and the tribal community. So all the necessary changes, we hope, need to be in effect by July 16, 2022. That's when 988 goes live. And actually, 988 right now, if you have, let's see, it's T-Mobile, and there's another one, and I'm blanking. There's two telecommunication providers right now who, if you dial 988, you're going to get the crisis text line, the National Suicide Prevention Crisis Line, not text line, National Suicide Prevention Crisis Line, 1-800-273-8255. You'll get it now. We're not nationally not really saying anything about that right now, simply because it's not universal. It won't be universal until July 2022. And so for those people who kind of stumbled onto it, I've had one person stumble onto it. I'm like, well, that's a perk you have, but not everybody has it. And so that's the limitation. Next, in 1 year, exactly 1 year, we're going to have that. And right now, we need to think about it from the perspective of what else do we need? Because one of the requirements that telecommunication providers have to do is they have to implement a 10-digit dialing plan in areas that use 7-digit dialing and 988 as the first 3 digits of the number. So for those areas that are using 988-555-555, they have to reroute their numbers. And so this is where the North American numbering plan administrators are working to reroute all the numbers and make sure we have adequate coverage number-wise for the telecommunication providers. All of that has to be in place before, in July 2022. So that's the hardware. And as you know, me being a computer kind of type person, that's the hardware. What about our software? What are we going to put into place that once that person calls 988, then what? What's going to happen? And what do we want to see happen? And does that mean that these crisis service centers need to have more training? Do these crisis service centers need to have more individuals who are Native, tribal-based people? Do these crisis service centers need to actually be part of tribal communities? I would love to see that. What do we need? So this is where we need to get into those other pieces. So what are we waiting for? We're waiting for the outcome reports on texting and geolocation. It was supposed to be done by May, June this year. Waiting for those reports. As soon as I get those reports, as I tell everybody, I will send them out on our listserv for IHS. So if you're not part of our SASP listserv or our Zero Suicide listserv, please get on those. It's at ihs.gov/DBH. Join those listservs because that's where all of my information gets pushed out. I do provide a very small emailing list to people I know who are working in tribal communities and working in be it urban or tribal programs in suicide prevention that have been there a number of years. I always send it to them as well for their information. The pieces that we have to think about as well as these next steps is the impact of COVID. Now, that's not something I've discussed because we don't know what the impact of COVID is going to be. And I know tribes are very worried about this. What's going to happen? And all I can say, because I've been asked, do you think there's going to be an increase in mental health issues related to COVID, to the pandemic, in this next year? And all I can say is what I know of the literature, having looked this up, that during the epidemic of the SARS-1 in Hong Kong, China, 1 to 2 years out after that epidemic, there was an increase in mental health needs for older women. That's what we know from history. What does that mean for us? We don't know. This is something, as Deb Stone from the Center for Disease Control and Prevention likes to say, more to come. We don't know what's going to happen. What we do know that's happened is that the rate for suicide within the United States for general population only in 2019 actually did decrease slightly. We don't know if that holds true for the specific special population, subpopulation, American and Alaska Natives. I'm waiting for that report yet to come out. And again, Once I have that report, I will share it. We don't know. We don't know what that's going to mean for us specifically. Usually when the CDC does these type of reporting out on the suicide rate, they then break it down by population, but those reports usually go about 6 to 12 weeks later. So they just released that report. It was about 2 to 3 weeks ago. So it's still some time between then and the next reporting batch on population. So again, once I get it, I will send it out. What do we know about the COVID? Has COVID been increased in mental health issues? CDC, I do know CDC has been working on reports in that regard, but we're still only 6 months out from the end of 2020, and the pandemic is still going. So we don't know what that actually means. It's just not enough time between the onset and now to be able to speak to it. So more to come, but we do need to think about that. So keep that in the front of your mind. Think about it from that perspective. So what do we need to discuss? What questions do you have? What ideas do you have? What concerns do you have about the implications for 988 within Indian country? What are some opportunities and barriers for this? What is it that we need to really pay attention to? Because as we look forward, you know, I always say this, that there's going to be short-term, there's going to be intermediate, and there's going to be long-term plans that we have when it comes to 988. What I need to know are what are those hot topic issues that in the short term, that by July 2020, we need to have in place. Example, we need to have cell towers in place in certain tribal communities that don't have infrastructure. We need cell towers. That's a short term for me. Long term is how do we increase services so that when a caller calls to the crisis line, that they can then get routed back to those services. Well, how do we need to develop them? Who do we need to include? How does recruitment and retention play into this? How does peer support paraprofessionals play into this? It's a big issue that has many, many iterations, phases, situations. What do we need to pay attention to? So with that, Courtney, do we have any questions? Does anyone want to raise their hand and have a discussion? I would really, really love to hear from you.
We do have a few comments in the chat box I can read while we wait for people to either type more in the chat box or raise their hand or unmute themselves. So we have.
Let's do that.
Okay, so we have Scott Barton. He said, I would like to see if we can meet after this conference to discuss this further. I am currently serving as the state of Connecticut 988 rollout team and have been looking for input on how to best include specifically the 2 federal and 3 state recognized tribes in this process.
Scott, feel free here. I'm going to put my email address up. There we go. Send me an email because you're not the only state that contacted me on this. And then we're going to try to find someone. But like I said earlier, I would rather help you find somebody in the community versus a tribal leader, because tribal leaders are very busy people and they may not necessarily know what's happening on the ground. And a lot of times the tribal communities have somebody that is on the ground working in this field who know it, but I may not know them. So, and I totally admit that I'm one person for 574 tribes. But we can start looking for those people, and it may take a little bit of time. But send me an email, we'll look for them, because I have a couple of contacts up Connecticut way that we can ask and see if they know of anybody on the local level that we can connect you with. So I appreciate that. Thank you, Scott.
We have another comment from KS. Please take into consideration the Alaska Native population in Kotzebue and the outlying remote villages regarding use implementation of this much needed crisis line.
Just, you hit the nail on the head with that one, Kate. It's Kate, right? Kate?
KS, I'm not sure what the initials stand for.
KS, okay. I heard Kate, KS. Yes, this has been one of my big issues as I've been going forward. There's actually a lot of discussion out of the White House about 988. And that discussion should be ramping up within the next month or two. One discussion point that was pushed forward by our colleagues at Department of Interior, Bureau of Indian Affairs is we need consultation, we need confer, we need to talk to tribes. This is something that I've been making people aware of as often as I can, specifically for Alaska, because we were talking about different areas and realities of different tribes. And I said, you know, and how is this going to work in Alaska? and they're like, well, what do you mean in Alaska? And I'm like, you're talking about vast distances. You're talking about rural, remote tribal communities. You're talking about a lot of barriers. And some of those, and actually a lot of those kind of tribal communities don't have infrastructure for this, you know, and they've been ravaged by COVID. How are we going to do this? Definitely keep you in mind. You're actually one of the, like Havasupai, Alaska is the other one. Is if I don't bring in Havasupai, I usually say how is this going to work in Alaska, because I don't, to be fair and honest, I recognize that, you know, they're human beings just like me, and we're sitting there at these tables and having these discussions. But I also recognize that not a lot of people have that frame of reference when it comes to Alaska and the vastness. And I mean, people don't have that conceptualization for even Montana of the vastness. And how do you work with that? And how do you help that in that kind of situation? So we'll definitely keep Alaska and keep pushing Alaska, as if it can work in Alaska, then we could probably get it to work down here in the lower 48. So I appreciate that. Thank you, KS. Any others?
A follow-up from KS, which is Kirsten Sundin. She works with the Manilac Health Association in Kotzebue. Okay, she wanted to reach out to her. And we have a comment from Patrice Post. Oh, we have two comments from her. I'll read both of those. She said, let Vibrant know who the contacts are in the tribal communities who would like to participate so they can share with the Lifeline Center's state grantees to be included in her during the planning of 988. And then she also said, for Alaska 988 planning, please contact Leah Van Kirk, and her email address is in the chat box, so you can get that. As they have a specific group that is working with rural and tribal communities regarding access.
Right. Thanks, Patrice. I really appreciate that you're on. We need to get to Vibrant. And that's the hard part, because I was on a call with them, a month ago now. And this is the exact same message that I said on that call as I'm saying today, is like, we need to find the people on the ground. We need to find people in the community, because, and I totally admit it, you know, my contacts are tribal leaders, and it can take some time. And it can take time to find the people who are really the people that need to be at the table. And sometimes that's not the people you think. And I want to be as understanding and empowering of that, because I do know of many tribal communities within the lower 48 and Alaska, that the people who are the most responsive, the most connected, are not necessarily always the people who are in the programs. They're the people who are the traditional healers. They're the people who are the kinship network. So the grandmas, the grandpas, the aunts, the uncles. I had the opportunity in 2019 before the pandemic, go up to Fort Belknap. And many of the people in the community who were the most outspoken and the most interested were veterans. I had veterans calling me, emailing me, saying, hey, you know, veterans have a high rate of suicide. How do I help? What do I need to do? And so we were able to get them connected with a different program that provides QPR services to them. And that program went up from New Mexico to Montana and went up and trained people. Any veteran and their family who sit down on QPR, they offered to train. And so when we think about these coalitions, we have to think about it from the people on the ground, because my experience is that we want those people to come to the table. We want them there because they're the ones that have the connection. You know, you can always email me, you can always call me, but I'm going to have to go I'll have to work with the people I know to find the people. And Natives, As a Lakota woman, all my networks are informal networks. These are the people that I don't necessarily always just email or text. I actually Facebook a lot of them. And these are the people that will call and say, hey, what do we need? What's going on? And then we go and find those other connections. So it's very informal, but it's very culture based. And that recognizing how we as Native people interact with each other and really learning what that means to the coalitions is really important. I can't stress that enough, is that when you're looking at tribal communities and tribal nations, it's different cultures. Literally 574 cultures, and I believe 400 states recognized, or I want to say 400, I might be wrong, but there are hundreds of them. So we're talking about a lot of different tribes. So want to be as culturally aware as possible. Thanks, Patrice, I really appreciate it. Courtney, any others?
Yes. Jerry Rainingbird said the state of Washington is developing a tribal specific service hub in response and anticipation of the move to 988. So something to be on the lookout for.
Jerry, yeah, it's good to hear from you. They are. Washington is doing such great work, and I should have thought about this, but I admit I've kind of been running around very busy. Should have had you present, because what the state of Washington is doing, I would love to see that in so many other states that have high populations of tribal nations, because what you're doing is such great work. So if you're willing to share an email, pop it in the chat so anyone else that's doing this in other communities can find out what Washington's doing, because the work you're doing is great. If you want to pop off out of mute and give us a quick rundown, I would love it, because I know of it, but I'm not in the thick of it. And so I admit I don't have enough information to talk about all the good work you're doing. So if you want to do that, feel free. Otherwise, we'll move on. But appreciate you giving that to us. It really means a lot. Thank you.
Everyone should be able to unmute themselves if they do want to share and not type in the chat box. If you have any issues unmuting yourself, let me know and I can unmute you.
Yeah. Any others, Courtney?
Yes. Shakila Yazi. Currently, DBMHS on the Navajo Nation continues to face barriers related to staffing, partnership, responding, et cetera, in providing crisis services into our communities through our 3 crisis response teams on Navajo.
Yes, so I had, thank you, Shakila. I had contacted Navajo area. This was about a month ago, actually, with that very issue. It was brought to my attention by a family who was really struggling. And so this is something that Chief Inez, who is my behavioral health consultant out in Navajo area, we have a lot of discussions about this back and forth, because it is an issue. And COVID, adding on that layer of COVID, had just been absolutely horrendous. And how do you keep staff safe? How do you keep patients safe? How do you provide services without having to involve 911? Because that's an issue too. It's like, a lot of people don't want to contact 911 because of their concerns and how long it takes. And, it's not that easy. So anything I can do, Shakila, feel free to email me. But we know that there's been a lot of difficulty within at least the last month that I've been made aware. So if you have any new information, feel free to email me, and I'll pull in all the right people that need to be pulled in, and how can we help with this? Because we want to make sure that your crisis services are working and they're able to get to the places that they need to get to and provide the services that they need to provide. Because this model that many of, like Samson and other fellow agencies are pushing, is that very model. But the pieces that are not really aligning is, how do we provide that support? Because you can set up these mobile crisis response teams and say that we have them, but how do we support them? Because these are people too. And if they're connected to EMS, if they're connected to 911, how does that gonna look? How are we gonna provide services and funding to them? How, all the who, how, why, and the other piece that we didn't talk about, jurisdictional issues. You know, there's a number of tribal lands, federal trust lands, federal reservations that actually go over multiple states. How's that going to work? Especially with the service centers that are state bound. So again, all of these issues are pieces that we've been pushing forward. I say we, like it's the royal we. It's me that I've been pushing forward. But it's how do we build this out so that there are more people that come to the table? Because as someone very respectfully said to me, you're the only one person and you're only one tribe. And it's true. I'm only one tribe. So what do we do? And this is where I'm hoping that, you know, feel free to throw in your thoughts, because how do we build this? What do we need to do? And yes, I'm looking towards you, simply because I want more people to come to the table. Go ahead.
Oh, this is Shakila, and I make the comment about our crisis response teams. And so right now, from what I know, we don't really see a lot from our area office. Maybe I don't see it as well, maybe at a higher level at my leadership. But I know underneath our tribal organization, we're actually underneath the tribe, and we had been staffing a crisis response team that actually does intervention into the community. But because Navajo is so large, it feels we've only had 3 active, and that's out of an effort that has been started by President Ned when he was vice president at the time. And so I think that's kind of where it is nice to see that we are moving forward. But right now we're not really, or I haven't seen anything on the IHS side to kind of start planning our crisis center. But that might be different. And then the same with, like, because currently we work through our dispatch, so our police department. So our police department does get a call about suicide ideation or even behaviors. And so then they have to be the middle person to dispatch us. And now with COVID, we're not able to go out. So before, our staff used to go out into the communities, drive to the area. And that's even hard too, because we're so rural and people are like, oh, well, I live 5 miles off of this dirt road. And so even those kind of barriers that we see, I guess that's kind of where I'm coming from, is it's really nice to see a lot of the movement in urban areas and in the smaller communities. So I'm just kind of figuring out where Navajo is in that picture, because it's so vast and so rural, and we don't have internet, we don't have water, we don't have electricity, and we face that too, providing services. So I guess just to keep that in mind when we're looking at those barriers and challenges that tribal communities and organizations are facing.
Yeah. Thank you, Shakila. One coworker of mine, he's up from Navajo Way, and I keep doing this, so I'm pointing west. He said that. He said, how's this going to work, like on Fort, because he's from Fort Belknap. How's this going to work when the directions to someone's house is go down to mile marker such and such and take the dirt road, and when you get on the dirt road for about 2 miles, you're going to come to a T, you need to go left. That is like the most perfect situation. You know, I grew up in Pine Ridge, same thing. You know, we don't, that's a local level knowledge base that is so important to include in this. And as I've been kind of going back and forth with some of the state coalitions, that's the piece that I really want them to kind of pull in and start to really understand, is that we are dealing with vast distances. We're dealing with very unique challenges, reservation to reservation, tribal community, urban area to urban area. And there is no one way that's going to fit everything. We're all very different. And COVID just adds a whole new layer to this. And so I appreciate you, Shakila. I really do. Feel free to email me and let me know more, because like I said, I got to do a report to SAMHSA that's highlighting all of this and really needs to conceptualize this to them, that as we're doing these plans, we need to have the best intentions to our tribal nations as possible. Because like I said, I'm one person. I don't know all of these situations. And so the more you give me, the better the outcome. It really is. So thank you. I really appreciate that. Any others, Courtney?
Yes, we have a few more. So Melina Oringa said it would be so helpful to have teachers on reservations to get mandatory training in suicide prevention so they can give immediate assistance to students and our people in the community.
I agree. Melina, you hit another nail on the head. Right now we do a little, we don't do a lot. I just was able to help one of the reservation boarding schools connect to the area to do training right now, just for you guys' awareness. Kind of connected to 988, but kind of not, just kind of like all came at the perfect time. Right now, IHS, again, we're doing a bunch of training within IHS to train our staff into question, persuade, refer. In addition to that, we're also training the trainers. And so what the plan is that every area, all 12 areas, will train additional people as a trainer in QPR. And what I want to see happen is that those trainers then go out and train as many people as possible. Either that to support of the area, support of the tribe, so that more and more people like that can get into training schools and EMS and police and everybody who will sit down for an hour and train them on what do we need to recognize for suicide, because specifically our youth, the leading cause of death, suicide. So we need to train people. So if you want to shoot, I'm only telling people, email me, and I end up with like 200 emails. And I do my best to respond to every one of them. But I always say, email me so I can connect you to people at your local level that I know of that could help you train, because this is a piece that I've been working with Bureau of Indian Affairs, and Teresa Paul over at BIA has implemented a contract for mental health first aid training. I know that's not for tribal schools because not all tribal schools are BIE, but I do know that she also has a network of people that she can help work to get mental health first aid out. We also have another division called Department of Community and Clinical Services, DCUCS. I might be wrong on that acronym. Marcy Ronyak, she has a number of mental health first aid trainers as well out in the areas, predominantly I'm blanking on who they are. They're basically they're the people that look at disease prevention, health disease prevention and promotion. No, not promotion, health disease prevention, something like that. Anyway, most of the areas have a few of them out in the communities doing different types of trainings. A lot of them are nurses, but a lot of them are mental health first aid trainers. So if you want that, shoot me an email and I'll get you in contact with that division if you want mental health first aid. It's an 8-hour training, but it's a good training. I used to be a trainer. Really great training. Thank you for that, Melina. Any others, Courtney?
Just a few more. And again, I want to encourage everyone to please feel free to unmute yourselves and share if you don't want to type in the chat box. Jerry shared a website for the tribal media campaign they're doing in Washington. It's www.nativeandstrong.org. He also shared his email and phone number in case anyone wants to reach out to him.
Thank you, Jerry.
And then Karen Kansens said thank you for the helpful information. So those are the last of the comments in the chat box. Again, please feel free to unmute yourselves and share.
Other things that we're doing, I know this isn't like the update time, but we're doing gatekeeper training. We're training people up. We're hoping to have all our trainers done. This is June, July, August, September. We should have a number of trainers already ready to go. We're hoping September, October, just in time for the school year. So if you want to know who those trainers are, most of our areas actually do have a number of trainers at local areas. So if you want to access those, definitely let me know. Again, if you want mental health first aid, our other division provides mental health first aid trainers for that. Downside with mental health first aid is 8 hours versus QPR, which is 1 hour. But it's more in depth. Mental health first aid teaches a lot more soft skills. So those communication skills, which is great. In regards to the coalition building for the states and looking at what SAMHSA is doing and what we're trying to help SAMHSA do, and again, you know, Richard McKeon has been so helpful and so thoughtful in regards to what is it that we need to know. You know, feel free, if you know of somebody who has ideas or who has had thoughts or who's mentioned this to you, feel free to share my email. You know, it's a national email. Anybody can email me and let them know and have them say, you know, hey, I've been thinking about this. What do you think? It's like, well, email Pam. That way she can put it in the report and get it to the people that need to get it to. And we need to have all of this information as we go forward, because what I know is that there's so many situations that I can't speak to because either number one, I haven't encountered it, or number two, it hasn't occurred to me. And so the more information you share back with me, the better. Also, what do you need? That can go into the report as well. That I can send that to my leadership and say, this is what we need in regards to suicide prevention in specifically tribal communities and urban areas. If you're from an urban area, please email me. I always hear from tribal. I don't hear from urbans. Would love to hear from the urban and what urbans are dealing with. I heard from the one urban and they wanted to have more connection with the county and city crisis services, and I'm like, we can definitely put that in the report. But what else? Especially for the urbans, you know, 70 to 75% of our population lives in urbans. I live in an urban area. You know, what else needs to be taken into consideration? A lot of urban Indian organizations out there, and I don't know all of them and their particular issues. So if you know anybody, let them know. And then also think about it from the perspective of who do we need to have at the table? Again, if you have ideas, I can tell you right now, Connecticut was just a state that identified that they're looking for people. So if you're from Connecticut and you want to help, definitely shoot an email. But if you know in your state, for your tribe in that state, and you know somebody or you are that person, email me so I can pass that information on. And we can get the coalitions, the people that they're seeking, and they need to build out these services for 988. You have to recognize that as Vibrant, who is the organization that oversees the National Suicide Prevention Lifeline, they're taking all this into consideration as well. But again, you know, we're human, we're limited. And so the more information I can send to them, the better that hopefully their plans will be. And as they're going in, from what I know, now, Patrice, feel free to unmute and, you know, pop in. What Vibrant has been doing is they did grants to the states to help start working on this. So the coalition building and starting to build out the services for 988. The grants were only open to states. They were not within the tribes. And so that's one of the aspects that we have to think about, is that how do we get involved with states? And what are the opportunities, what are the barriers, what are the challenges of doing so? Now, I know personally through my work is that a lot of tribes have a lot of issues when it comes to states, that it's very difficult to get services through the state because, especially if you come from a tribal community that's on a trust land federal reservation, that those individuals, the misconception that they don't provide any income to the tax base is what I usually hear. Therefore, the state says you're not going to get services through us because you don't provide anything. Misconception, but how do we bridge? Knowing that, how do we bridge? Because we recognize that they are still, tribal communities are still located within those states, and they still have, you know, the state and the tribe still has interplay with each other. And so how do we bridge that? Can we bridge that? And if so, how do we help that? And in some places, we're going to do a great job. Some places we may not, and that's okay. But we have to do what we can wherever we can. So feel free, totally open. Let me know. Like I said, I usually get about 150, 200 emails a day. I do my best to return emails. So just be patient with me if you email and you don't hear for a couple of days. I will get back to you. But I really wanted to thank you for your time today. If you have anything else, you want to unmute and have a discussion, feel free. Would love to sit and talk with you. Anything, Courtney, any other comments, questions, concerns?
I do have a comment from Jonathan Lowry.
Okay.
I'm representing Nevada Urban Indian Inc., located here in Reno, Nevada. I am the current Substance Abuse Suicide Prevention Coordinator. We work alongside the 27 tribes here in Nevada. And I'm also a member and resident of the Pyramid Lake Paiute tribe. I'm very grateful for the information on the 988 program, and we are definitely interested in learning more about the program.
Wonderful. Shoot me your email for your name and your contact, and I can get that over to Patrice and her people so that they have, the State Coalition for Nevada has your information, and we can make sure that we make those connections so that people are working together in concert to figure out all of this as we go forward over the next year. So thank you, Jonathan. I really appreciate that.
That is the last comment so far in the chat box.
Okay.
If there's any other questions or comments, please feel free to either type them in the box or unmute yourselves.
If not, I'll give you a minute, because I know I usually take time to figure out what I'm going to say. But I really wanted to thank you today for letting me to come and have a discussion with you, present this information that Richard has developed. I really wanted to thank Richard McKeon again for all the information that he's provided to everybody, not just me, to everybody about this process. And really wanted to thank you for those of you who provided your information. We need to do this with you. Can't do it without you. So I really wanted to thank you for your time, your attendance today. And then if you have anything, you need anything, feel free to email me. We'll do my best. And then unless there's anything else, I can let you guys go early.
Before you all sign out, I just want to remind you to complete the sign out portion for this particular session. You received a link along with the sign in link. Once you click that link, it'll take you to a brief little survey you need to complete. And after that, it'll take you to the evaluation. We are asking that you please take some time to complete the eval. It helps us make sure we're providing webinars that are helpful to you all and providing information that you're looking for. And it also helps us plan for future webinars that we intend to host. If you have any questions or comments afterwards, please feel free to contact myself or Pam if they're in relation to the 988 number. If there's nothing else, we will go ahead and wrap up this session. The next session will begin at 15 after the hour. So Eastern Standard Time, will begin at 2:15. I know everybody's in different time zones. So I just want to let everyone know that. You can hang out in the Zoom room. You'll be in the waiting room until the next session starts if you happen to be joining us for the elder abuse and neglect session, which will be in this room.
Thanks again, everybody, and have a good day.
Thank you.